My name is Matt. I'm from Seattle, and I'm here to introduce you all to Dr. Monica Krzyzanowska. She's a medical oncologist at the Princess Margaret Cancer Center, University of Toronto, in Toronto, Ontario, Canada. Her research program aims to improve the quality of care received by cancer patients. She combines patient level studies focusing on specific quality issues in the oncology population, such as drug safety and toxicity, with population based research. Dr. Krzyzanowska obtained her medical degree in clinical training at the University of Toronto and completed a research fellowship at the Center for Outcomes and Policy Research at the Dana-Farber Institute in Boston. She earned her Master of Public Health from Harvard University. And today, the session is titled Navigating Access to Systemic Therapy for Advanced Thyroid Cancer in Canada. And with that, I introduce you to Dr. Monica.
Thanks, Matt. It's a pleasure to be here this morning. And clinically, I treat a lot of thyroid cancer patients, so it's a pleasure to be here and to talk to everyone this morning about navigating access to systemic therapy for advanced thyroid cancer in Canada. So today, what I'm hoping to, is what I'm going to talk to you about is a couple of things. So first, I wanted to give you an overview of the sort of principles of management of advanced thyroid cancer as far as it comes to systemic treatment. Then to talk about what the systemic treatment options for advanced thyroid cancer are in 2021. And certainly the menu of options has really expanded in the last few years, which is really great news. And then to specifically touch base on the access to systemic treatment for thyroid cancer in Canada. Advanced thyroid cancer is considered a rare condition, and that plays into the access piece for drugs in Canada. So I thought I would start by just sort of going back to basics and really talking about what it is that we mean by thyroid cancer. A lot of people don't really appreciate, unless they're either working in the field or have been affected by thyroid cancer, that when we talk about thyroid cancer, it's not really one disease. It's actually many diseases within sort of one umbrella. And so this is sort of a complicated slide, but let me walk you through this. This really talks about the different types of thyroid cancer that are out there. So the majority of thyroid cancers originate from the follicular cell within the thyroid, and they account for maybe 90 to 95% of all thyroid cancers. And the majority of those are what we call differentiated thyroid cancer, with the two most common histologies being papillary thyroid cancer and follicular thyroid cancer. There are some sort of rarer histologies like Hurdle cell and poorly differentiated thyroid cancer that are on this side of the slide as well, but I've listed the most common ones. In the middle there you see anaplastic thyroid cancer, which is a rare but very aggressive form of thyroid cancer. I will touch base a little bit about this at the end of my presentation in case there's any patients or caregivers or family members who are dealing with anaplastic thyroid cancer, but the majority of my talk today will be focusing on the differentiated and the medullary thyroid cancer. So on the right-hand side of the slide, you have the medullary thyroid cancers. Those originate from a different cell within the thyroid. We call it the C cell. And medullary thyroid cancer, about 2/3 to 3/4 are what we call sporadic. So that means that they are, it's not due to a family history or a family predisposition. And then about 25% to 30% at what we call hereditary thyroid cancer. These often occur in the context of multiple endocrine neoplasia type syndromes. So there's family history, multiple family members are affected. And there's a lot of these weird names that you can see on the slide called BRAF, Hras, RET, and while I don't want to necessarily get into a lot of the details, but the reason I've listed them here is that if you are a patient who has advanced thyroid cancer, or a family member whose loved one has advanced thyroid cancer, you're probably hearing about these molecular abnormalities. And thyroid cancer is there's a lot of molecular abnormalities that we see. And why it's important is that in 2021, some of these abnormalities are actually affecting the types of treatment choices that we're making. So it's actually very important to understand, if you have advanced thyroid cancer, if there are any of these particular molecular abnormalities. So for example, in my practice, I do molecular profiling on all of my patients to try to figure out, does their cancer harbor one of these mutations, because it might affect some of their treatment options and some of the treatment choices. Not sure why this isn't working the way. Okay, here we go. So I thought what might help us with the discussion this morning is really to utilize a case. And this is a case from my practice. I have been managing advanced thyroid cancer for about 15 years, or probably a little bit longer. So this is a case from some years ago of a man who was in his mid-40s who was referred to me with metastatic papillary thyroid cancer. And this was about over 10 years ago now. So, the treatment options have evolved a little bit. And at the time when this patient was referred to me, he had had surgery about 7 years prior. This is on his thyroid, followed by the first dose of radioactive iodine. Unfortunately, his cancer recurred in the neck, so he went on to have another operation and another dose of radioactive iodine. And then the cancer unfortunately came back one more time, this time in the mediastinum, which is the middle part of the chest. And then he underwent third surgery and had another dose of radioactive iodine. And this is probably around 2007, 2008. And he was being followed by his team, which at that time, usually patients were being followed by surgeons, endocrinologists, and sometimes nuclear medicine teams. And on his follow-up scans, what was shown that there was some new lung lesions, and that one of those lung lesions had grown from about 1.4 to about 1.6 centimeters. And this is in the late 2000s. And at that point, there was some buzz was starting in the oncology community that there were some new treatment options for thyroid cancer. So the question was, should this patient now be started on systemic treatment beyond the treatments that he's already had? So that's often the first big question when patients get referred to me is, should this patient start systemic treatment? So we know they have advanced thyroid cancer, but not every patient with advanced thyroid cancer needs to start on treatment immediately. So let's maybe talk about some of the things that I and my colleagues who treat advanced thyroid cancer consider when we're making decisions around treatment. So I did want to say a word about radioactive iodine, and this is for the differentiated thyroid population, and obviously this is not relevant to for example, the medullary thyroid cancers, because they are not radioiodine avid ever. So this is really on the differentiated side. So radioactive iodine is used usually initially in the setting of high-risk disease. So maybe after initial surgery, patients might be recommended to undergo radioactive iodine to decrease the risk of the cancer coming back. This is often the first treatment that's also offered when the cancer does come back. And radioactive iodine, at least in Canada, is usually given by endocrinologists or nuclear medicine physicians, and also in a few places by radiation oncologists. Before patients are eligible or should be considered for the systemic treatments that we're going to talk about this morning, we really need to decide whether there is any more room or role for radioactive iodine. So in the oncology community, we've come up with a definition of what we call when somebody's disease has become radioiodine refractory. And that usually means that there's either no uptake on their radioactive iodine scan, or even if there is uptake, their cancer has progressed quickly after radioactive iodine, and in thyroid quickly, we would consider 12 months. Or if they've had multiple doses and it's getting, the risks of radioactive iodine are becoming too much. So that's our current working definition for being radioactive iodine resistance. So for this particular patient that was referred to me, I'll show you a picture of his radioactive iodine scan, but at that time he had progressed within 12 months and had 3 doses. So we were already getting concerned that perhaps more radioactive iodine didn't make sense. And in fact, he did go ahead and have a radioactive iodine scan, and this was 12 years ago now, and there was no uptake. So then our options at that point in time were, should he be starting on systemic treatment? And in 2009, options were a little bit more limited, a lot more limited than what we have right now. The other concept is this idea of active surveillance, which means maybe we're not starting a new therapy, but we're following patients closely. And when we talk about active surveillance, the question really is, what do we mean by that? Do they need to be seen every couple of months? Could it be a bit longer? In fact, does it seem like maybe they should be sent back to the referring physician and just the referring physician would follow them with scans and then we refer back to medical oncology when there's more disease or the disease is progressing more rapidly. And then we sometimes, we always ask the question, should we be considering any sort of local therapies like radiation or more surgery? So how do we decide in terms of if someone should go on systemic treatment when they have advanced thyroid cancer? And these principles actually apply both to radioiodine refractory differentiated thyroid cancer as well as to medullary thyroid cancer. So these are similar considerations. The only difference between the differentiated and the medullary being that the radioactive iodine question is not relevant for medullary thyroid cancer. So first is that issue, that concept of natural history. How quickly is this changing? Is this a 2 millimeter growth on a CT scan over a course of a year? Or is this a few centimeters of growth over a few months? The other concept is the concept of disease burden. So is this 1 or 2 spots somewhere, or are we, does this patient have disease in their neck and in their chest and perhaps in bone, for example? Also disease location. So we do worry about certain areas. If it's close to a critical organ in the neck or in the chest, or maybe it's in a weight-bearing bone like in the hip, are they symptomatic or are they asymptomatic? Many patients with advanced thyroid cancer initially will be asymptomatic and will not have any symptoms related to their disease. In oncology, we often talk about this concept of performance status. So how well is this patient? Are they fit? Are they able to look after their activities of daily living? Because that impacts their response to treatment as well as the chances of side effects. I have to be honest, with thyroid cancer, especially differentiated or medullary thyroid cancer, oftentimes when patients get referred to me, their performance status is excellent. Sometimes they tell me, if I didn't know, like if someone didn't see this on scans, I wouldn't even know I had advanced thyroid cancer. This is different, for example, for anaplastic thyroid cancer, when patients often, when they get referred, they're quite sick. They often have a lot of symptoms and sometimes they're not feeling so well. And then obviously, last but certainly not least, is patient preference. The systemic treatments do improve outcomes from the cancer perspective, but they come at a price, and those are the side effects. So I always have a conversation with patients around what their preferences are, what's important to them. And in this particular case that we're going to talk about, there's actually patient preference did play quite a bit of a role because he was the primary caregiver for his family and the primary breadwinner, and starting on treatment could impact his ability to earn a living. So back to this case. So this was the CT scan that we had back in 2009. And just to orient you, so that when we look at CT scans, we actually look kind of across people. So this is a CT scan of the chest. And so this is kind of slicing you, the pictures are kind of across, maybe at the mid-level. This big white thing in the middle is the heart, and then the sort of black areas here where the arrow is the lungs. And what I just wanted to tell you is that most of this looks normal, except there's this one little kind of this is the sort of biggest nodule that we can see here. So I think in this particular scenario, my assessment at the time was that their disease burden was fairly low, and the progression was quite slow because we had seen only a couple of millimeters of growth over a course of a year. So I think it would be quite reasonable to follow the patient expectantly without starting systemic treatment. And also to remind you, this was back in 2009 when we didn't have a big menu of treatment options except clinical trials. But even at that time, this would not actually meet criteria for a clinical trial, which shows clear progression and larger burden of disease. So back to this particular patient. So what we decided at that time that we would choose the option of active surveillance. And so when you think about active surveillance, there's a few things that you need to consider. So this is the type and timing of the imaging. So are you going to be doing scans every 3 months, every 6 months, every year? And I'm very cognizant of the fact that many of my patients with advanced thyroid cancer, I will be following them for several years before they need treatment. And so I have to be cognizant how many scans, and there's not a lot of radiation with each scan, but there is some. So that needs to be considered. And also because the disease can behave in a different way, just sort of trying to strike that balance, and hence the yin and yang of doing enough scans, but not so many that to put the patient at risk. There's also the concept of clinical follow-ups. I will often alternate to scans, not at every visit, maybe every other visit. I talk to my patients that, if you get a new symptom and you're not due for your follow-up, just give me a call our clinic, and we'll see you earlier. So if you're getting a new cough that's unexplained, or something is hurting that wasn't and it's persisting, please call, and we can see you earlier than your scheduled appointment. And then the other thing that I think is important is this concept of molecular profiling. I started my presentation by showing you that complicated slide with many of these molecular abnormalities. I think in 2021, I think molecular profiling is very important for thyroid cancer, because we do see a lot of molecular abnormalities in the thyroid cancers, and those may be actionable. So I do usually recommend at a time when patients are being considered for systemic treatment or are being referred into my practice that we consider molecular profiling. Unfortunately, it's the access to molecular profiling has been a challenge, and I don't think that's just in Canada, but in general across the world. We have been lucky, for example, at my institution, that we've had an institution-wide study where we can molecularly profile tumors and sort of have that available to us. Otherwise, it's either through private pay, and actually recently in Ontario, where I practice, Cancer Care Ontario has approved a few of the biomarkers and the biomarkers that are matched to therapies, that we can order those now and have that publicly funded. I guess the one disadvantage with having molecular profiling right at the time of diagnosis is that there has been significant advances in our in how we do molecular profiling, the kind of platforms that we do. So for example, when we started doing molecular profiling, we generally could just pick up mutations in a single gene, versus now in 2021, we're picking things like fusions between different genes and other slight sort of more nuanced alterations, which in fact can open up treatment options, like for example, with the RET rearrangements. So doing molecular profiling a little bit early before treatment starts may the technology may advance, and we might be able to pick up new things closer to the treatment starting date. The disadvantage, I guess, would be that if things were to change more rapidly in someone's clinical status, the molecular profiling does take some time. So then you have to wait for those results. So I think my message for everyone on the webinar is that if you don't want to start too soon, but then at the same time, you don't want to miss the window for treatment. So with my patient, I continued to follow him quite regularly. And as you can see, we're now in 2013, so about 4 years after I had been following him. And at that point, on the CT scans, his neck disease started to become really more pronounced. I always ask again for the surgeons, this patient has had multiple surgeries, but I've asked again, by any chance, should he be having more neck surgery? He does have distal disease, but always worthwhile the ask. And the answer was no. We talked about systemic treatment, but at the time, the patient was still preferred to not start systemic treatment, as they were working and had a relatively young family. And we're actually, other than the scans, we're feeling quite well. So at that time, the decision was made that he would proceed with radiation therapy to his neck, and had a good response in the neck. We continued to follow him very closely. By 2014, early 2014, we were picking up, if you remember that original CT scan that I showed you, this is the heart once again. This is that lesion that I had shown you before, has grown, but then some of the other smaller lesions have become bigger. Interestingly, he was still asymptomatic at this point in time. He was working full time. He was a busy dad. In 2014, we were starting to do more molecular profiling and also doing some immunohistochemistry on which is another type of pathologic technique. And in this particular case, we noted that his tumor harbored what we call a BRAF V600E mutation. This is a common mutation in thyroid cancer. And the important thing about this mutation is that it's actionable, at least in 2021. In 2014, the BRAF inhibitors, which is a class of drugs, were just becoming available, mostly for the treatment of melanoma, where this mutation is quite common. But this was something that we knew about his cancer and sort of kept at the back of our mind. At this point, he's still reluctant to consider treatment. So we decided to follow him closely. At this point in time, I think I was seeing him in clinic every other month just to make sure that we don't miss him getting clinically worse. So maybe this is a good point to talk about the systemic treatment options. So I've included a slide on chemotherapy, but mostly really from a historical perspective, because pretty much in 2021, this is obsolete. So up until sort of the mid 2000s, like 2005, this was really the only option, with the drug doxorubicin or adriamycin really being the main treatment. And I have to be honest, the results weren't great. And so pretty much in 2021, we don't use chemotherapy, traditional chemotherapy for thyroid cancer. The one exception is anaplastic thyroid cancer, where we do use a drug called paclitaxel still in 2021. And so between 2000 and 2010 was really the first kind of phase when we started doing clinical trials of these new targeted agents in thyroid cancer. And initially, we called it initial mixed bag of patients. What I mean by that is that, when we do, for example, clinical trials in colorectal cancer, or oftentimes when we start doing clinical trials, everybody who has colon cancer would be put in a clinical trial, and then we would try a treatment and then follow patients and see what the outcomes are. And so initially when the thyroid cancer trial started, any patient who had advanced thyroid cancer could be enrolled, and this meant that patients with papillary thyroid cancer and medullary thyroid cancer would be in the same clinical trial. And as we now understand, these patients respond differently to different agents. And so nowadays, and I talk about that in the next slide, is we don't do sort of these mixed trials, although we do mixed trials, but with the same molecular abnormality, and I'll come back to that. In oncology, for many other cancers, the disease progresses very rapidly. So as soon as we see metastatic disease, oftentimes patients would be started on treatment. But thyroid cancer is a little bit different because the disease can progress very slowly and patients may not require treatment for a long time. So initially when the trials started, anyone with metastatic thyroid cancer could be enrolled, and then patients would be followed and not much difference would be seen on the CT scans, and then we didn't know, is this because the drug was ineffective, or was it because this is how the natural history of the particular cancer was? And so that actually, after that initial experience, the eligibility criteria for trials did change to include this idea of disease progression before someone went on a clinical trial. Most of these trials were small studies with single arm, and the focus was very much just, did the tumor shrink, and really little information on things like what was the quality of life. If as I think I've mentioned, and I'm sure many of you are living this, sometimes when you have advanced thyroid cancer, you may be asymptomatic, and starting on therapy does bring symptoms because there are toxicities, and we'll talk about those a little bit in a minute. And so people didn't look initially in those trials whether the quality of life was impacted. So then that brings me to the contemporary trials of targeted agents, and the contemporary era really sort of goes back to about 2005 and on, when big randomized trials started being undertaken in thyroid cancer. And we participated in many of these trials at Princess Margaret, trials of drugs like vandetanib or lenvatinib or cabozantinib. And these were big global trials across many countries. And these were usually histology specific, so either focusing on the differentiated or the medullary thyroid cancer. And nowadays, some of the trials are, for example, are maybe more focusing on molecular abnormalities. So for example, for the RET inhibitors, the selective RET inhibitors, which are probably the newest class of drugs to be used in thyroid cancer, they allowed both RET positive medullary thyroid cancer as well as some of the other RET altered differentiated thyroid cancer. Most of the contemporary trials were much larger, so not 20, 30 patients, but a few hundred patients. And for that, we did need to have a global collaboration and more relevant patient outcomes beyond just did the tumor shrink on CT scans. Things like how long did it take before the tumor started growing, the quality of life impact. The one limitation of all of these trials is that we still don't really have a lot of information about the long-term outcomes. So did these, starting on these drugs, did this improve patients' overall survival? The thought is that probably yes, but it's much harder to sort that out because if someone goes on first line of therapy and they're on treatment for a while and then they go on second line, it's really hard to figure out which drug is doing leading to those improvements. So what are our systemic treatment options for iodine refractory differentiated thyroid cancer in 2021? And I'm going to talk about medullary and anaplastic separately because the options are different. So I call the, so trying to move this so make sure you guys can see. So for the molecular profile agnostic, so meaning that we don't need to know the molecular profile of the tumor, and they were tested in settings, these drugs were tested in settings where there wasn't a particular molecular profile that they were targeting. The three main drugs are lenvatinib, sorafenib, and cabozantinib. All of these drugs work in some way on angiogenesis, which is formation of new, sort of inhibiting formation of new blood vessels. I've added little superscripts talking about Health Canada approval, reimbursement by provincial plans, or Health Canada approval for another indication. I'll come to the drug approval issues in a minute and how that works in Canada. So we have the sort of what I call the profile agnostic. And then we do have some drugs in 2021 that are available for specific molecular abnormalities. So we talked about BRAF mutations, which are that's probably the most common mutation in thyroid cancer. And we do have BRAF inhibitors, dabrafenib and trametinib, for example, that are available in Canada for treatment actually of melanoma. We also recently have had the approval of two selective RET inhibitors called selpercatinib and palsetinib. So patients, you might have heard of them as Loxo and Blue. And the NTRK inhibitors, specifically larotrectinib, which is a drug that targets a somewhat rare alteration it's actually a gene fusion, which occurs in thyroid cancer, but also many other cancers, but is not very common.
Well, we do have a question about molecular profiling and the cost of it. A couple parts to this one. What is the approximate cost of molecular profiling in Ontario? Is it self-pay or covered by the institution that requests the profiling? Is access for molecular profiling similar across Canada? And on average, how long does it take to get the results?
Okay, so let me try to tackle those questions. And so, so the cost of molecular profiling. So there's different so the menu of molecular profiling is actually increasing. Okay, I'm just trying, it's nice to, so the menu of molecular profiling is expanding. So we have molecular profiling involving the tissue. So, so this could be like an existing biopsy or maybe from the time of your thyroidectomy, we have some tissue on file, or it could be a fresh biopsy, but that's profiling the tissue. The newer kind of, although, and I'll talk about the pluses and minuses, the newer approach is using something called a liquid biopsy. So, and using like pieces of DNA that's circulating in the blood to try to figure out what might be some of the molecular abnormalities. Molecular, like sort of, and you can do sort of selective molecular profiling, looking at specific alterations. So for example, like the BRAF change. like the BRAF molecular abnormality, or you can do something called more comprehensive. So we often call this next generation sequencing, or NGS, and that gives you a panel of many genes and many different alterations, and you're kind of trying to sort of figure out what could be abnormal. So then comprehensive next generation sequencing is not covered in Ontario, and I don't think anywhere else actually in Canada. Recently in Ontario, and I'm sorry, I don't know about the other provinces because this is very recent in Ontario, as recent as September, the government has approved more targeted molecular profiling for the few abnormalities where there are biomarkers for treatments like RET or BRAF. In terms of cost, usually it's a few thousand. If you're gonna, so at Princess Margaret, we've been very fortunate because we've had a molecular study running for several years now, 5 to 8 years, where we've been able to enroll patients and molecularly profile their tumors, and that would be free of charge to them. But I'm not sure that many other provinces have access to that. Some of the other, ask your oncologist if there is anything like that available in your particular jurisdiction. If it's not, then you could pay for the molecular profiling. Like for example, Foundation One is one of the sort of most commonly utilized platforms, and that's anywhere between $3,000 and $6,000. And from what I've been told by my patients who've prefer to go that route, or is that they might ask you about your income, and then they can support the amount that, so if you meet financial need, you might pay a little bit less, and if you don't, then a bit more. But because we've had access to the study at Princess Margaret, we've been pretty fortunate that most of our patients were able to take advantage of that. And then the liquid biopsy is a more recent thing, and we haven't been making a lot of access from that. The advantage of the liquid biopsy is that it's just a blood draw, right? Versus for the sort of more comprehensive molecular profiling, you need tissue. So you either have to have archival tissue available, or you need a new biopsy, which is an much more invasive test. The advantage of having the full molecular profiling is that you're looking at a lot more genes. The liquid biopsy has a smaller number of genes that they're looking at. So those are sort of the advantages and disadvantages of the molecular profiling. And I'm happy if there's other follow-up questions to get into those. In terms of clinical trials, so most of the clinical trials in thyroid cancer these days are either very specific to the site, like it's papillary or it's medullary, or to a molecular abnormality. So for example, it's this is a BRAF, like they're looking at a BRAF inhibitors. So the two trials that I know are sort of coming up in one that's open. So for example, for patients with metastatic medullary thyroid cancer, for those who have mutations, RET mutations, then we have a trial that's actually open at Princess Margaret, and I think at least one other site in Canada. If upfront sort of frontline therapy, our current treatment is a drug called vandetanib, which is this sort of agnostic category. But with the development of the RET selective inhibitors, the big question is, should you be starting with the RET selective and then go to vandetanib, or should you start with vandetanib and go to RET selective inhibitors? So we do have a trial running at Princess Margaret, which is a global trial. So we're one of the sites called Libretto, looking at vandetanib versus selpercatinib, which is one of the selective RET inhibitors. We will also have a trial coming up, a second-line trial for patients with differentiated thyroid cancer who have a BRAF mutation, to look at BRAF inhibitors after progression on first-line therapy. So clinicaltrials.gov is a good website to look at what trials are running globally and what's available. We always try to open up the trial, any of the global trials at Princess Margaret, to have our Canadian patients have access to them, because it's very difficult to travel to another country to go enroll in a clinical trial. And I know because I've referred patients down to the US when we haven't had appropriate trials for them. So I hope that answers, okay, hopefully that answers some of your questions. Okay, so maybe I'll go back to Matt, anything else?
Yeah, we have how close is Health Canada to approving Debrenafib and Trimetinib?
Trametinib.
Yeah.
I don't think it's actually, it's not very, to be honest with you, I don't know because it's, I don't, this is, would be considered sort of like private information that Novartis, who makes those drugs, would have, right? Because it's up to them to submit and it's up to then Health Canada to review. So why don't we actually, this is a good slide. Let me talk about how drug approval works. And so Health Canada basically provides authorization for drugs to be marketed in Canada. And it's usually, they don't sort of blanket approve the drug like, okay, like they're approving it based on sort of safety and efficacy. And so they usually have them for specific indications. So for example, lenvatinib, which is one of the drugs that's used in thyroid cancer, was initially approved in Canada for, their initial indication was for thyroid cancer. Now the drug has been tested in other types of cancers, like liver cancer, and so they might add additional indications. So the dabrafenib and trametinib, which is actually approved in Canada for melanoma, is marketed in Canada, but it's marketed for melanoma, which means it doesn't have a label for thyroid cancer. And I don't know when it will, if it will. It partially depends on whether the company will submit or not to Health Canada for approval. And part of that is actually based on the evidence that's available for that particular drug combination. Most of the data on the BRAF inhibitors and thyroid cancer are smaller kind of single institutional case series studies, so not a big randomized clinical trial. So once the Health Canada sort of approval is made, that means nothing about coverage. So the coverage is usually made at the level of each individual province. And one good thing that has happened in the last several years is that instead of each province reviewing the evidence and making decisions on reimbursement, there is now a pan-Canadian oncology drug review committee called PCODR, which uses a very standardized and very rigorous and transparent process. If you go to their website, you will see sort of how they do this to make decisions on whether, to make recommendations on reimbursement by the provincial plans. And as part of that, there is a patient consultation. So they're often looking for patients to provide input on specific drugs, if those drugs are beneficial. And I know sometimes they've approached some of my patients because they've often been some of the first ones trying some of these drugs in Canada to comment, on quality, because they've participated in a clinical trial, for example, of a specific drug, to comment on quality of life and, does it fill a need, etc. And then the PCODR makes a recommendation on reimbursement, and they can either, usually falls into three categories. Yes, this drug should be reimbursed. No, this drug should not be reimbursed. Or yes, the drug should be reimbursed, but there should be some sort of a pricing modifications. Many of these drugs are very expensive, and so so sometimes they will say, well, yes, this drug does have benefit, but it's very expensive. Let's go back to the sort of negotiations table. So just to give you examples from thyroid cancer, drugs, so for example, lenvatinib was recommended for reimbursement, sorafenib was not, and then larotrectinib, which is that specific drug for the NTRK mutations, which was actually not just for, it was actually approved not for thyroid cancer, it was approved for patients with any type of cancer that harbors that particular molecular abnormality. I think it was the first Canadian approval, which was based on a molecular abnormality, not on a type of cancer. They were recommended to sort of go back to the drawing table around the pricing. And then sometimes when drugs don't have Health Canada approval, and that might be because it has not yet been submitted to Health Canada, or that's often the case. It's usually that it hasn't yet been submitted. They may be available through compassionate access programs. So a company might say, we will make this drug available through compassionate access. And that often involves the physicians. So for example, for me, I'm often have to apply to health, like the company would say, yes, we will provide this drug to your patient, but I have to apply to Health Canada to get special access for this particular patient, and then to the company to get access to the drug. And then it's quite a complex process and a lot of paperwork. But we have for thyroid cancer, because it's a rare cancer, and in Canada, oftentimes it doesn't, the submissions for sort of indications for thyroid cancer can happen much more quickly in like in the US or in Europe, because it's a bigger market. The companies will often make submissions to those markets first before they come to Canada and submit for that indication. And then one other point I should make, that if a drug is marketed by Health Canada and it has a label for a specific indication, but it does not have reimbursement. So for example, a drug like sorafenib, which has Health Canada indication for thyroid cancer, but is not reimbursed because it felt like it didn't meet the kind of the yes recommendation from PCODER, can still be sometimes reimbursed by the private drug plans. So if somebody has private insurance, they might be able to access that drug as well. And oftentimes, if the private insurance doesn't cover the full cost of the drug, the manufacturer will pick up the gap, which might be 20 or 30%. So it's very complicated, to say the least. Okay, so back to our case. So for this particular patient, remember we were in 2014. He wasn't quite ready to start. I had recommended, and this was around the time that 2015 was around the time when lenvatinib became available in Canada more widely. And but he was still very reluctant. He was working full time. He had a family, and he really wasn't interested in starting treatment. So we continued to follow him, and then in January of 2017, he started to have a lot more cough that was now interfering with his ability to work. And and you can see the two big spots there. And then we started him on lenvatinib. And this is just on this slide, what I'm showing you is this is the sort of picture from before that you just saw on the previous slide with the two bigger spots, and literally 6 months into treatment with lenvatinib, this is now this bigger spot. It has shrunk quite significantly. And then the other larger spot, which we saw right in the middle there, has also shrunk quite a bit. So really nice response in terms of the imaging, and his cough had actually improved. And after managing his side effects, he was actually back to work on treatment. So I wanted to, I didn't want to forget about medullary thyroid cancer, and time is short, but great questions. So a little bit about medullary thyroid cancer, because the treatment options are a bit different. So in terms of the molecular profile agnostic treatment options, we have two drugs, vandetanib and cabozantinib. Vandetanib is both Health Canada approved and reimbursed by the provincial plans. Cabozantinib is neither Health Canada approved for thyroid cancer nor reimbursed by provincial plans, although it is available for other types of cancer. So it is marketed in Canada. So technically you could potentially try to get access to it. There was a recent study that just came out a couple of months ago for second line for differentiated, like for radioiodine refractory differentiated thyroid cancer with cabozantinib. So the Health Canada approval might change, but I don't know. I'm not privy to that information. And then probably the most exciting recent developments in medullary thyroid cancer is with the RET-specific inhibitors, because as you might recall from the first slide that I showed you, RET mutations are extremely common in both the inherited and the sporadic types of medullary thyroid cancer. And we now have two selective RET inhibitors, selpercatinib and pralsetinib, and these have just gotten Health Canada approval in Canada in the last couple of months, or they're just coming out, but they're both are going to be approved. I don't think they're yet commercially available, because once the marketing authorization happens, then it takes a little bit of time before the manufacturing gets aligned. But anyway, they have both been available before, like in the last year, by compassionate access, and I'm sure it's going to go to PCODER for review, and hopefully will then go into the provincial plans for reimbursement. So I did want to maybe spend a couple of minutes talking about side effects, because obviously these drugs, while they are can be effective. They are effective. They do come with side effects. So I don't have time to talk about each one of them, and they all have some of their unique side effects. I wanted to just maybe spend 2 minutes on lenvatinib, which is probably the most commonly used thyroid cancer drug at the moment. And so this is sort of a table that we often see in the clinical trials with the different types of toxicities that were experienced by patients while on the trial. And what you can see that the three sort of most common things that we can see in patients are high blood pressure. So when patients start on treatment, and if any of you had been on or are on lenvatinib, this can happen very quickly. And I'll talk about how how my management has evolved for hypertension for this particular drug. As patients are on the drug for a while, they can often lose weight. And this is very specific to lenvatinib, the weight loss issue. And as you can see in this particular trial, 42%, 68%, for example, had hypertension. So like 2 in 3, 3 in 4 patients had high blood pressure, and then any kind of elevation of blood pressure. And almost 1 in 2 had quite severe elevations in blood pressure requiring multiple drugs to manage. With the weight, 1 in 2 would have weight loss, and then 1 in 10 would have severe weight loss. And then proteinuria is basically when you're leaking protein in your urine. 1 in 3 patients had any evidence of proteinuria, and 1 in 10 had serious evidence of more severe and symptomatic proteinuria. And that can show up as having maybe, you start getting swollen legs and retaining a lot of water because of the protein loss. So how I approach management, so I believe truly in proactive management of the toxicity. So don't just sort of, start the drug and see what happens. So I often will make sure that at the baseline, I often do very full scans, including a scan of the brain, just to make sure that there isn't any asymptomatic brain spots, because if your blood pressure goes up with the drug and you had an asymptomatic spot on the brain, there's increased risk of bleeding. There's this whole concept about the starting dose. So in the clinical trials, the starting doses often are the sort of the maximum starting dose. And if someone is a little bit more frail or maybe not as strong, then perhaps you don't want to start at the full dose. You might want to start at a slightly lower dose, although a recent study showed that if you do start at a lower dose, maybe the amount of shrinkage is a bit less than if you started on full dose. When patients start on treatment, I'm very clear with them that, you're going to be seeing a lot of us for the next few months until we sort of get you on a dose that you tolerate and that we've sort of figured out most of your side effects. So we see patients every 2 weeks. With the pandemic, we've done a little bit more of this virtually, which has actually worked okay. But pre-pandemic, we'd be seeing you in clinic in 2 weeks. We have had nursing or pharmacy involved with it as well. So sometimes our pharmacists will check in with the patients. In terms of supportive management, I have now started giving my patients, when I start them on some of these drugs, like for example, lenvatinib, I will give them a prescription just in case to have on hand in case they needed to start a blood pressure medication before they see me in 2 weeks. Because as I mentioned, the blood pressure can often go up very quickly. If they're having diarrhea, which is a common side effect for vandetanib or cabozantinib, we do give them like a prescription for loperamide, so just that they have it on hand. And for weight loss, which tends to happen a bit later with lenvatinib, not really right at the beginning, we've played with different kinds of approaches. And I think what I've been doing more recent over the last few years is, rather than keep dropping the dose and keeping the patients on drugs, I give patients like a treatment holiday. And I find usually like 1 or 2 weeks of treatment, they kind of regain their appetite, can sort of get back, all the GI side effects sort of settle down. And that seems to, I think, work the best, because you don't want to because otherwise you just keep dropping. And obviously it's very important to talk with your patients around the self-management piece. For example, for the blood pressure, it's really they're at home on these are all oral drugs. So oftentimes they will be provided with a blood pressure cuff, and we ask them to measure their blood pressure, and if they're seeing trends that the blood pressure is going up, to give us a call even before the 2-week follow-up if need be. And I've had some of my patients, it's been amazing. They come in with these little diaries with all of their symptoms, and then we sort of work collaboratively to try to make adjustments. So I did want to, and I'm cognizant of time, we have just wanted to maybe just One word on anaplastic thyroid cancer, very the rarest form, luckily, but very aggressive. Usually, there's no talk about can we wait to start treatment. Patients present with usually very rapidly progressing disease, often very big neck mass. That's much more limited treatment options, but I do have to say things are evolving. And specifically, there is a very high prevalence of BRAF mutations in thyroid cancer. So this is where the BRAF inhibitors have really taken off in terms of being utilized. There is lots of buzz about immunotherapy in this particular setting. And then we are still using, if there is no mutations that we can target, we are using mostly paclitaxel-based therapy and obviously any kind of local therapies. Matt, can I just check in with you because we have 10 minutes and I have a few more slides, but I want to make sure we at least address some of the questions. Is there like any other things in the chat that we should talk about before our hour is up?
We do have just maybe 3 or 4 questions. What treatment options are available for HRAS mutation in Canada?
Excellent question. So unfortunately, HRAS or RAS mutations are probably the second most common mutations after BRAF mutations. At the moment, there are no approved agents for RAS, no RAS inhibitors. But because RAS mutations are very common in many other cancers, this is a very active area of research. There was recently a study that was published in the New England Journal of Medicine for lung cancer with a drug that inhibits RAS. So I think this is coming. But at the moment, it would be through a clinical trial with some of these new RAS selective inhibitors. So most of the RAS patients, we would treat them. So lenvatinib is okay because it's molecularly, it's not for a specific mutation. Cabozantinib, which is sort of the newest kind of kid on the block for the differentiated RAS mutated thyroid cancers, would also be okay. But for the selective, like for the RAS inhibitors, nothing approved yet, and I'm not aware of any specific thyroid trials, but the RAS inhibitors are coming, and so there will be trials. Although those would probably be more like what we call basket trials, where different types of cancer with that mutation would go into that trial.
How do you determine the starting dose for levantinib? Do you always start on 24 milligrams?
Great question. The answer is no, I don't always start at 24 milligrams. I tend to, so 24 milligrams is tough. So usually, 24 milligrams, I would start someone who is very fit and sort of strong and has probably no comorbidities. So that would be the type of dose. On the other hand, someone who is very frail, I have a few 80-plus-year-old patients who are very frail and small, and I think 24 milligrams might be too much. But I have, because of the recent trial, looking at the dosing and the impact of dose on response rate, I do have a conversation with patients around. Like if we start you on a lower dose, it may be the tumor may shrink less, although we don't know if it means that it's going to not work as well in the long term. I've had many patients who've started on 14 or milligrams and have been on the drug for several years now. So I usually have a conversation with the patient, and the whole thing about watching them very closely at the beginning. If they're going to go on 24 milligrams, I might be checking in with them in a week, not in 2 weeks.
And you did touch on this question. I have metastatic medullary thyroid cancer and have run the gamut of treatments, including liver resection. My next option is either selpercatinib or pralsetinib. However, I'm informed that there is a supply shortage to Canada. Are you aware when they will be available?
$1 million question at the moment. So they have both, I think both, at least one of them has received full approval from Health Canada, but I keep reaching out to the companies to sort of say, hey, when is this actually going to be available in Canada? Because now we're in this sort of funny zone of the compassionate access programs have both closed. So only if you've been on the drug already does the company continue to supply it. And it's not yet commercially available. Once it becomes commercially available, it's still not going to be covered for some time, because even it has to go through that whole review process, which takes probably about a year. So I'm not sure what's going to be happening in that time in between. So that's as much as I know. And you know, I touch base with those companies because I have many patients in my practice who have medullary thyroid cancer, and you know, I've used these drugs and I can see their effect. For this particular patient, if you have not been on any systemic treatment, and you said you've run a gamut of therapies, so I assume you've had vandetanib already. If not, then we do have that clinical trial open up front, but it's a randomized trial, which means some patients get randomized to vandetanib up front, others to the RET selective inhibitors, because we're trying to answer the question, does it matter which one you go on first, right? So that's as much as I know about the availability of the RET selective inhibitors in Canada at the moment.
And we have about 4 minutes left. One more question. Could you comment on clinical trials in Ontario and the rest of Canada for thyroid cancer for both papillary follicular, but also medullary? Is it included in trials for solid tumors?
So, so we do, as I mentioned, with the two trials, that the one that's currently open in Canada is probably the first line medullary trials, trying to see whether the RET selective inhibitors versus the vandetanib or cabozantinib is sort of the optimal. It has to do with the sequencing of treatments, right? And then the other trial that's coming is the second line trial for the BRAF selective inhibitors. We do have, if your particular tumor does harbor any other kind of mutation, that's why the molecular profiling is so important. If it does, then there may be some other selective trials. Often those are run through what we call early phase or phase 1 clinical trials, and certainly there's early phase, like there's phase 1 programs. We have one at Princess Margaret. There is a phase 1 program in Vancouver. I think there's a few other centers. So certainly speaking with your oncologist or endocrinologist to see what trials may be available, and they may make inquiries on your behalf. And then don't go into clinicaltrials.gov website to sort of search and see what might be open. And the one thing is that because there's not that many thyroid treaters in Canada, like there's like it's a rare cancer, so we're a smaller community. We do all pretty much know each other, so we oftentimes, you know, my colleagues will reach out to me, I will reach out to them, and you know, try to find options for our patients.
Do you always use lenvatinib for a known BRAF V600 mutation, or do you start with dabrafenib, trametinib first?
So, I mean, lenvatinib was tested without looking at molecular profiling, and the response rate in the SELECT trial were very high, like 70%. So lenvatinib is an excellent first choice. Where I tend to use BRAF inhibitors up front in my patients is if I'm worried. So one of the unique side effects of lenvatinib is because of this anti-VEGF kind of properties, anti-angiogenesis, there is a small risk of a complication called fistulization, which means communication between two different areas that shouldn't normally be communicated. And in patients with thyroid cancer, they have disease in the neck, and there's, for example, disease between the esophagus, which is the swallowing tube, and the trachea. I worry because the lenvatinib works so well, like things shrink very quickly, that there is an increased risk, I think, of creating a fistula, and the communication between the swallowing tube and a breathing tube is not a good thing. It's a very serious complication. So I've had a handful of patients where I've been worried about their neck or their mediastinal disease, that if they develop that they are at high risk of fistula, where I have started with the BRAF inhibitors. I have to be honest, access to BRAF inhibitors is not an easy game in Canada because they're not approved for this indication, but Novartis does have a special program that we've been able to take advantage of for those patients. Or some patients have had private coverage because there is data.
And I think we are out of questions. So if
Great.
Nothing else, we will call this session to an end and let everybody go on with their day.
Great.
We appreciate your session and your answers to all our questions.
Well, I hope this was useful, and I'm sorry I can't see you, but thank you for your attention this morning, and hope that you found the session useful.
Thank you, everybody.
Thanks. Bye-bye.